You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 8th, 2018. This week, I'm talking about cardiovascular risk reduction, a fascinating case report of treating bradycardia with medication, cocaine, and marijuana use as it pertains to myocardial infarction, the electronic health record, and vitamin and mineral supplementation. So first up is predicting the future. This is no easy task. Heart disease is a common cause of death, and if we could get better at predicting it, certainly that would be a good thing. Remember that in 2013, the PCE, or pooled cohort equation, was rolled out with the new lipid treatment guidelines. The pooled cohort equation was decent because it was easy, but numerous studies since then have shown that it often mispredicts risk, which of course is bad practice because if it overestimates, it medicalizes many asymptomatic people. That PCE equation also had problems with underestimating a patient's risk as well, especially in African American patients. Now, investigators from Michigan aim to improve the PCE accuracy, and they were going to use the same PCE equation on newer data, and also they were going to try different statistical methods. The Annals of Internal Medicine published a series along with an editorial. So in the first method they used, the investigators used the same derivation method as the original PCE, but they applied it not to the dated Framingham cohort, but to 6 longitudinal cohorts, ones that you've probably heard of before, like ERIC and the MESA cohort. The second way they approached this problem was making another set of equations using revised derivation methods. So the main finding from this paper, when using the second method, which was the new statistical methods, when they used newer data and different statistical methods combined, the revised PCE reduced overestimation among the general population compared with the original pooled cohort equation. This new method also reduced the problem of extreme risk estimates for Black adults. Now, the third finding of this paper is that it was not enough to simply use the same PCE equation on newer data sets to get better prediction. One would have to use different statistical methods. The statistical methods they use in this paper are kind of complicated and over my head. The big clinical implications, however, is that using this new revised PCE, as described above, would reclassify many patients below the 7.5% threshold for recommendation of statins. Now, the authors discuss limitations of the paper, and they smartly call on other independent authors to reproduce and validate their revised PCE and to use it among additional cohorts to identify whether the equations derived by them still outperform the existing ones. I'm drawn to this paper because I despise medicalization and over-predicting risk, and so if this revised PCE is borne out to be better, I think this would be a great thing. The revised equation looking better in Black patients is also especially attractive as well. Hopefully others will take up the challenge of confirming this data. The second topic is about a case report. Now, I hardly ever do case reports, but this one is fascinating, and it also deals with an issue that comes up quite a bit, at least at my hospital. Published in the Annals of Internal Medicine. The authors are from Florida, the Mayo Clinic in Florida. They describe a very old gentleman with permanent atrial fibrillation and symptomatic bradycardia and hypotension that was not due to other medications. This man had many comorbidities, and the group did not want to have to put a permanent pacer in him, primarily dementia. So they tried anticholinergic drug hyoscine, and it worked. The mean blood pressure and heart rate steadily rose to the point of getting the guy back to the facility. And they kept him on the drug 4 times daily and returned in 1 month with a heart rate of 73. Now, of course, this is only a case report, but it's super cool because we struggle with the decision to implant pacers in patients like this. We don't want to implant a pacemaker because they're very close to end of life and there are risks to the procedure. But then again, it seems crazy to not treat profound bradycardia. So if this drug, this anticholinergic drug, is tried by others and it worked, it might be another addition to include in an experienced doctor's bag of tricks, especially in these difficult patients. Third topic today is cocaine and marijuana use. Now, as we muster stronger responses to the terrible opioid epidemic, more people seem to be going back to the old standby drugs, cocaine and marijuana. We've been seeing more of that in our hospital at least. Now, that's why our report, led by Harvard researchers, published in JACC, is so timely. The investigators retrospectively reviewed younger patients who had a type 1 MI over a 16-year period from 2000 to 2016. They determined the substance use by self-reporting and also by drug screens. And they found that about 10% of patients, young patients, used either cocaine or marijuana. It was broke down about 5% for cocaine and 6% for marijuana. Most surprising was that the use of substances associated with lower rates of diabetes and lipid abnormalities, but substance users were more likely to be smokers. Now, cocaine and or marijuana associated with a higher CV mortality. The hazard ratio there was about 2.22, with confidence intervals 1.27 to 3.7. The hazard ratio for cocaine use was 1.91 for all-cause death, and the hazard ratio for marijuana point estimate was 2.09 for all-cause death, and the confidence intervals were above 1, so they were significantly increased risk. Now, I agree with the authors of this paper who state that cocaine is a known risk for MI. We've seen this for years, and that isn't such new news. But the more interesting issue here is the marijuana use. Marijuana use is clearly increasing as states legalize it, and so we're going to have to learn more about this substance. I am not sure marijuana is a risk in and of itself, or if it just keeps the company of other risk factors. For instance, marijuana users tend to be more sedentary. Perhaps they're more obese. Perhaps they're higher risk of smoking. Is it those risk factors, or is it the marijuana itself? I think we have a lot more to learn about marijuana use and cardiovascular risk. The fourth topic today is the electronic health record. A new Harris poll conducted for Stanford shows that a clear majority of primary care doctors favor a complete overhaul of electronic health records, or EHR. That same survey found that 40% of doctors find more challenges than benefits using the electronic record. And get this, more than 70% of doctors think that the EHR contributes to burnout. That's a significant number. Now, perhaps many of our international listeners of this podcast have not been affected by electronic health records as much as us doctors here in the U.S. In fact, when I was in Calgary a couple of months ago, they haven't even initiated Epic systems, but they were going to. Now, here in the U.S., we have a couple of dominant vendors for EHR. And no one advocates, and I don't advocate, for going back to the paper chart days. But our EHR in its current form is terrible. The interfaces are not clinician-friendly, the interfaces are rigid, and they don't talk well to other systems. But all the woes are not just the EHR's fault of late. Another problem U.S. clinicians have is the added data entry we are asked to enter. For instance, I can see a patient with AFib and say they're doing well on their anticoagulation and beta blocker. Well, that's not enough. I have to enter data into a registry so my hospital and perhaps I can be graded and paid more, or at least be thought to be a better physician because of my data entry into the registry, which of course is nuts. Doctors entering data instead of caring and listening to patients is just plain stupid. Now, even more nuts, it gets worse. Here in the United States, and this is the worst part, we are strongly incentivized to make every person we see as sick as possible. We're supposed to bring as many codes over to the problem list. Now, we do this for two reasons. One is that the more complex the patient is, the more everyone gets paid. The other issue is that you could be a great doctor, and we're being judged, but you could be a great doctor, and your patient could have great outcomes. But if all your patients are straightforward patients, you'll score poorly relative to your colleagues who are bloating up their patients to be sicker with more medical problems. It's almost like a race to make people sicker. Now, the news article suggests learning from Uber and Amazon, but I'm going to stay skeptical on that. Healthcare has never been able to muster the courage to open itself up to freer markets and more meritocracy. U.S. healthcare seems to like it better with entrenched interests using regulatory capture to dominate the landscape. Until healthcare policy continues to be dominated by non-clinicians and administrator types, I don't expect much change in how we do things, which is sad. The final topic today is about vitamins and minerals. Now, not every day, but many days I am asked about vitamins and mineral supplementations. Will this help me? I see tons of people still on vitamin D supplements. Well, a very large systematic review and meta-analysis recently published in JACC confirmed previous studies and previous reviews and meta-analysis, and mainly they found that there is no CV protection from most vitamins and supplements, except this review had one caveat, and that they found was folic acid seemed to offer some stroke prevention in 2 of the 7 RCTs that were analyzed. And these 2 RCTs, the relative risk was 0.80, and the confidence intervals upper limit of confidence interval was 0.93, so it was statistically significant. Now, the lead author of the meta-analysis equivocated on whether this information on folic acid supplementation is sufficient to change practice, especially given that many foods are fortified with folic acid already. And that comment brings up the caveat that one of the large studies showing folate benefit for stroke prevention in the study was a Chinese study, and that's significant because of the lack of folate fortification in foods in China. Now, the big news here is not that. The big news in this study, and it's a worthy study, is that this is yet another confirmation that most vitamins and minerals are not beneficial, and we should tell patients this. I think the same story here, it's akin to the caffeine research that finds coffee and tea is not harmful. Telling patients vitamins may help or caffeine may harm in the absence of evidence creates a huge disservice to our patient, and the main reason is distraction. Distraction is key. We have proven ways to help cardiovascular health. That is to walk, be active, eat less food, eat better food, get out, socialize, don't smoke. These are what we should focus on. And when we focus on nonsense like vitamins and reducing caffeine, we distract people from the main tasks at hand that we know will help them. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. Please feel free to leave a comment. I'll see you next week. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.